Welcome to AETCM, the Emergency Medicine Channel. 56-year-old male patient, a known case of myasthenia gravis, presented to ER with a complaint of fever and cough since 3 days. On initial 10-second assessment, patient was conscious and oriented. Coming to primary survey, airway was patent, there is no pooling of secretions. Coming to breathing part, respiratory rate is 24 per minute and saturation 86% on room air. Chest examination, bilateral breeze and Krebs was present. So initially we put on face mask of 8 liter O2. Then we started on nebulization with levosalbutamol and levosalbutamol ipratropium. Then coming to circulation part, BP was 150/100 and heart rate is 86 per minute. Coming to disability, GCS were E4, V5, M6 and people's bilateral equally reactive and GRBC is 160. Then we done a reassessment. Saturation was not maintaining on 8 liter O2 and patient still on respiratory distress and tachypneic. We shifted to put on BiPAP 10:5 with FI to 80%. Then during that advanced to primary survey, we take an ABG showing pH is 7.42, PO2 is 66, with PCO2 40 and bicarbonate is 21. Along with potassium 3.5, sodium 130, lactate was 1.8.
Okay.
And, point of care also we taken, sir. So it's showing total count 12,000. CRP was 25.
Continue.
Then urgent to primary survey, we take a portable chest X-ray. Chest X-ray showing bilateral infiltrates. Then to go to secondary survey, 56-year-old male patient, known case of myasthenia gravis on pyridostigmine and on prednisolone since 3 years, presented with complaint of fever and cough since 3 days. Patient was able to expectorate the cough and clear the secretions. And patient also complained of breathlessness, which was progressively worsening since 2 days. Patient also complaining of worsening of breathlessness more during the evening, and he also noticed the increased drooping of his eyelids. There is no history of any weakness, vomiting, abdominal pain, seizure, or altered sensorium. Coming to systematic examination, CNS examination, bulk and power was normal, sir. Reflex also normal.
Cranial?
No weakness, sir. Ptosis there. On other systematic examination, also chest examination, bilateral V's and Krebs present.
You said that. So what's your diagnosis?
Patient is known case of myasthenia with a background of LRTA, suspecting worsening of myasthenia gravis to myasthenic crisis.
Okay, so this is a very straightforward history that you are giving. Patient with myasthenia gravis who had a recent LRTA and he has got worsening of symptoms and coming to the emergency room. So that is very clear. Here we are dealing with a myasthenic crisis. So when you have got this patient with myasthenic crisis, when will you say, okay, this patient has developed a myasthenic crisis? What are the parameters by which, okay, this attributes to myasthenic crisis? This is myasthenic crisis. How will you decide?
Normally, patient myasthenic crisis is defined by a patient requires respiratory, patient going to respiratory failure, like uses of accessory muscle and like dyspnea, accessory muscle usage, hypophonia, then bulbar palsy-like symptoms.
Yeah, that's the two things. You have to know whether it's a respiratory or bulbar involvement. So respiratory bulbar involvement, that is the initial thing, and they can also come with much early. If the patient is presenting, they will come with worsening of ptosis and diplopia. So diplopia, ptosis to start off with. Then when we say crisis as such, they ideally should have a bulbar weakness or they should have a respiratory weakness. So that is a major differentiating features from a simple myasthenia gravis and myasthenic crisis that we have to see. So now we have got a background history, this and this. So we are very sure that we are dealing with a myasthenic crisis. Suppose in the emergency room, you are not knowing that he is known case of myasthenia. So when will you start suspecting? Probably am I dealing with a myasthenic crisis? You don't know the background history at all. Because here you know that this and this thing is happening. Suppose you don't know he is having a myasthenia. The first time presentation of myasthenia gravis can be a presentation with myasthenic crisis. Very rare, but they can come with myasthenic crisis, bulbar palsy and all. So what will be the classical history that you will get in myasthenia gravis?
Normally, the weakness will progressively increase during the evening period or vigorous exercise.
So gradual progression of symptoms as the day prolongs. So the morning they will be fine because the muscle will start getting fatigued. There is no enough acetylcholine receptors and all those things. By evening time, more and more activity, and they will get more fatigue. So that will be the classical history that you will be getting. So within proceeding to the presentation, you need to ask about this history. And again, what will all be the complaint? They can come with diplopia, generalized tiredness, fatigue, and all those non-specific complaints. Not able to swallow,
clear the secretions, hypophonia.
So this will be the symptom. So that is what we have to suspect. And then you take an ABG. ABG, you are seeing oxygen, the hypoxia is improving, and the respiratory muscle pattern, the weakness, there is no inadequate chest movements. Then you are seeing that there is PCO2 built up. So that is the clues that you have to think, okay, probably am I dealing with a myasthenic crisis? So, or myasthenia gravis as a first time presentation to the ED. So now you said regarding oxygenation. So you said that you put the patient on BiPAP. Okay. Now putting on BiPAP is pretty simple, straightforward. But this is one condition where we should be putting the patient on this mode. There are on non-invasive ventilation, there is CPAP mode, there is BiPAP mode. In BiPAP, there is ST and AVAPS mode. So this is one condition where we have to put this patient on AVAPS mode. So what is the basic difference between an spontaneous timed mode and between an AVAPS mode? So can you tell me that what is the basic difference?
ST mode, we are putting the pressure, like we are putting the IPAP and EPAP pressures. In AVAPS mode, we are initially determining a tidal volume. To attain the tidal volume,
okay, the thing is that it is very simple. Spontaneous time, the patient is taking breath, and during each breath, how much during inspiration support is needed, how much during expiration support is needed, we are setting it up and the machine is delivering that. That's it. In AVAPS mode, the difference is that you are setting an upper pressure limit, you are pressing a lower pressure limit. So for IPAP, you are setting, this is the maximum pressure limit what I want. This is the maximum limit that I want. You are setting it up, and the machine, from each breath, the machine will determine how much the tidal volume is required, and the machine will deliver that breath accordingly. So for every breath, it will not be the same pressure that is required. So for every breath, the pressure will change. So one of the classical indication where AVAPS mode will function is this muscular weakness. This is muscular weakness, obesity, hypoventilation situations, and muscular dystrophy cases. Where there is myasthenia gravis, the better thing will be AVAPS, because the patient here is not generating adequate respiratory efforts. So other group of patients, COPD and all, they are having enough effort and tidal volume might be achieving. But here we need to assure that we are getting a fixed tidal volume. Maybe for each breath, we need to give different pressures. We don't know. Maybe as the pressure, as the respiratory cycle progress, maybe initially you started off him with a certain pressure. Maybe the machine is delivering only 8 IPAP. Later on for the next breath, it will be 12. So depending upon what is required for the tidal volume, and it will calculate the minute ventilation accordingly, and the machine will deliver. So that is a basic difference. So AVAPS mode will basically work very well for this group of patients. So ST mode and AVAPS mode, that is a basic difference. So when you read regarding AVAPS mode, the classical indication is such muscular dystrophy, myasthenia gravis and all, you can try AVAPS mode, which will be more comfortable to the patient, and you will have better desired effect. So that is a one difference that you said. Now let's come to the myasthenia crisis asset. So when you get a patient with myasthenic crisis, you have decided, for example, this patient, how you want to proceed. Suppose your NIV failed. So you have to look for why he has developed a myasthenic crisis. So you should look for the triggers of myasthenic crisis. So what are the common triggers of myasthenic crisis?
Normally there is infections, then pregnancy, childbirth, any surgical management like thymectomy.
Most common thing will be what? You are not giving the adequate doses of pyridostigmine. So that might be the most common cause. And the next will be infection. Infection followed by adequate drug is not being given to the patient. So that will be the two reasons. Then you need to differentiate between myasthenic crisis and cholinergic crisis also. Cholinergic crisis just like our OPC, organophosphorus compound, the sludge pneumonics that you can remember. Suppose the patient is having lot of secretions, lot of vomiting, diarrhea and all those things, you have to think we are giving excess medication. Over medication. That is due to the pyridostigmine that you are giving on additional doses. So you need to differentiate whether it is a myasthenic crisis or a cholinergic crisis. But usually when they come with bulbar palsy, respiratory weakness, it's mostly in favor of an myasthenic crisis. So now we have to see infection as one of the most common reason, and what are the other triggers that can cause worsening of myasthenic crisis.
Infection, surgical management.
See, drugs.
Drug.
That is the most important thing. Other things like antibiotics. Suppose they have gone and met a GP who doesn't know that he is having a myasthenia, or is not aware of the factor that he should be avoiding this drug, and he are given an accidentally, and which drug? Aminonucleic acid we don't give on an OPD basis.
Like fluoroquinolones.
Most commonly fluoroquinolones. Levofloxacin. They are given for a levofloxacin. For an LRT they have started on levofloxacin. That might be the macrolides, azithromycin. These are the group of drugs that can trigger a myasthenic crisis. So beta blockers, second group of drugs are beta blockers, cardiovascular drugs. Then
quinidine, primaquine, chloroquine, hydroxychloroquine.
So lot of drugs that we routinely use can worsen the condition. So you should know what was the precipitating cause. Now this patient is in front of us. Now what are our priorities? If the patient whether he has missed a dose or whether he is secondary to infection, we need to treat the both. So how will you decide that?
First of all, treat the triggering factor. Then we can, if there is any oral secretions is there, we can do suction and clear the oral secretions. Then we symptomatic management like nebulization we can start with. Then if patient is going to impaired respiratory failure, like able showing respiratory acidosis, in myasthenia one problem is they will mask the muscle usage. So patient going to respiratory distress, we cannot clinically assess patient is going to respiratory weakness because of weakness of the muscle. So we can take an ABG. In some patients we can do the vital capacity also. So normally vital capacity
in the ED you will never do. You can do only a single breath count. That's what you usually do. So single breath count is equal to vital capacity. I have never seen we doing an FE1 by doing a spirometry. There are handheld spirometry available. We can do that even for COPD basis. How they are improving, you keep one functional vital capacity machine and you can do that. But routinely it is not being practiced. So simple thing is single breath count. This patient you cannot ask for a single breath count. He's hardly is able to breathe. So that is very clear that he is desaturating. There is respiratory muscle weakness already started in.
So patient is going to mid respiratory failure. We will mechanically intubate the patient.
Okay.
Then we will start on
so precautions regarding RSI. So there has been a lot of questions whether to give paralytic agent, whether not to give paralytic agent. If you want to give paralytic agent, which group we wanted to give. So there is no contraindication. When you look into this, there is no contraindication. But when you give succinylcholine, the thing is that it will not act. There are no receptors for its action.
Already it is a depolarizing muscle relaxant. So basically the pathology is it is antibody against the ACL receptor. Succinylcholine is also acting on same receptor. So already receptors are less. So we will give, if we plan to give succinylcholine, we will increase the dose of succinylcholine. Then other choice is non-dipole muscle relaxant. They are already blocked the nicotinic receptor. Already there is antibody blocking there. So it is very sensitive to low dose of non-dipole muscle relaxant. So
0.3 when you give, 0.1 only will be required. Like rocuronium and all, you need not give the full dose 1 mg. You need not give the complete dose. You can give half the dose also. So that is a basic difference. So then the next thing, all other drugs we can use. There is no other major contraindications. So now we have treated the airway. So we have to treat the problem. So how will you treat the problem now?
Drug of choice is anticholinesterase like pyridostigmine, neostigmine. Before planning to give this pyridostigmine and neostigmine, we will keep on atropine because this will causes bradycardia, so like OP symptoms. So we keep ready with atropine and crash guard. So pyridostigmine we can give orally, we can give 30 to 60 mg 6th hourly, and neostigmine we can give also 30 to 60 mg 6th hourly, or injection IV dose we can give 0.01 to 0.04 mg per kg 6th hourly we can give. Along with that we can give atropine 0.6 mg
dose. To prevent bradycardia. That is just to prevent bradycardia. So, and the most important treatment is giving your drugs as early as possible. You should not be missing. Suppose he has missed those drugs, you have to identify and give IV drug or oral drugs has to be immediately started. So that is the most important stage of management of this group of patients.
Then we can start with the glucocorticoid like prednisolone. We can give 125 mg OD or 60 mg we can BD we can give higher dose glucocorticoid. Then we can give start with on plasma exchange.
That's all refractory IVIG, plasmapheresis, all those things. We can decide upon that later. We need not take that headache right now. Our primary aim is to see why he has worsened. Why he has worsened, and you have to treat the cause. And most important thing, don't skip the doses of the drugs whatever he was regularly taking. You have to understand that he was regularly taking that medication. On top of that, he has developed an crisis. So again, missing those doses will worsen the situation. And we don't have IV predostigmine available. So we have only IV neostigmine that is available. So give IV neostigmine, pre-treat with atropine to prevent bradycardia, and depending upon that, you see the patient is improving or not. What is then again, we were discussing initially, what is this ice pack test?
Ice pack test in patient with ptosis, we can do with ice pack test. We can take a surgical glove, put ice packs inside, then we can keep this ice packs on the ptosis eyelids. So if it is after 2 to 3 minutes, if the ptosis is improving, we can diagnose as
confirm it. So that's an easy thing that what we can do in our ED. So we need not do any blood test. We don't do anything else. Just keep some. We are suspecting some myasthenia gravis coming to the patient. You are saying bilateral doses. Keep an ice pack, roll it and keep it over the patient eyes. Take a video and see how he is improving. So you can show to the neurological resident that see he has improved. This is what, and you can straight away starting the treatment with all the neostigmine or pyridostigmine. If the patient is able to tolerate oral, pyridostigmine is well and good. So that is the, then what else we have to, cholinergic crisis, how will you manage?
Cholinergic crisis, like copy poison, we can manage with atropine. Then
so usually we don't need a prolonged infusion and all. Once the drug are stopped, automatically it will revert. Maybe a couple of doses of atropine itself will take care of all those secretions and the patient will improve. So that is only required for cholinergic crisis. And then what else we have missed? Myasthenia gravis crisis, yeah. And most importantly, when you have a patient with myasthenia gravis, always, whenever you are adding a drug, you, what I'll say, or you guys are doing, take a printout and keep, because a lot of drugs are there. We can't remember everything. So just keep a printout of which all the drugs should be avoided for that patient in the front of the sheet, so that we will not be repeating the same mistake or same drug which can precipitate a myasthenia, we will not keep. Okay, suppose you have a patient again improved, again you can do an neostigmine test also bedside. You can just give, you are suspecting myasthenia, give one atropine, give neostigmine, see whether the symptoms is improving. That is also a classical of an improvement myasthenic crisis. The patient myasthenic gravis, it's a confirmatory test again. So we can use the same way. If you don't have pyridostigmine, if you can give IV neostigmine and see how the patient is improving. So these are all confirmatory tests. Then you can send for the receptor assay, whether autoimmune antibodies are there, myasthenic assay and all those things can be
just to rule out any thymoma.
Thymoma. He had, I think he had a thymoma. So thymoma. And what are the other disorders that is coexisting with myasthenia? Very common.
Other autoimmune like
very common is thyroid. You can have autoimmune thyroid disease, either hyper or hypothyroidism. Both are possible. Hypo and hypothyroidism, both are possibility. So he already had a thymoma excision has been done. Okay, so he was admitted, and what antibiotic you will start for this chest infection then? You want to start a drug for the chest infection, no? What drug you will start? You can't start aminoglycoside. You cannot start.
So we can start with
penicillins.
Penicillin also.
It can precipitate.
Penicillin causes
Cephalosporin.
No.
Cephalosporins?
We can start.
Cephalosporins are there. You have group of drugs, cephalosporins are there, which we can start. So we should, because it's impossible to remember all the drugs. There are more than 60 to 70 drugs that can precipitate. So most common ones are antibiotics. So these are the most potent things that can precipitate the disease. So we should be knowing which you can safely start on this patient. Even tetracyclines, doxycycline can precipitate myasthenia. So we have to be very cautious in starting an antibiotic. We need to go back and refer and see what antibiotics you can. Cephalosporins, I have seen there has been no problems. We can use cephalosporins. Anything else that you want to add? Fine. Thank you.